very much under control. The number of cases has extensively come down. So we are very lucky. We don't know why. We've taken some precaution, but obviously.
Right. It is because of your praise, right?
Yes, yes. The only reason is prayer.
So, I think before we start, please start. We can talk. I mean, a little about everything. Dr. Fazlul Qasim, I think we have got our some senior teacher like Partho Sharati Shom is here, and Hassan Masood is here, and other people are joining. So, can you start? I mean, little before our
just 2 minutes, sir. We'll just start at the 4.
Okay.
It is 2 minutes to 4.
Introduction. Yeah.
We will just start, sir, at 4, sir.
Okay, that's great. So, great to see. Ramesh, we were expecting you in Dhaka. In fact, in the 22nd March,
looking forward to that. And then fate has other ways of dictating what we do.
Yeah, that was your plan to come to Dhaka. Yeah, I know. And that time.
We cannot hear you very well now, Rami. Previously, we could hear you much better. So your voice has come down.
Yeah.
Is that better or not better?
Yeah,
Not better.
It's good.
Not better.
Not better? Downstairs.
Probably Nicholas yet not joined.
No, he has joined.
He's here.
Yes,
Nicholas.
Nicholas. I cannot find him.
Hi, Nicholas is there. You find him,
Name.
Man, Godfather is here, man. Don't try to avoid him.
I'm not saying him.
He's in the
Nicholas,
center. He's in the center of the screen.
He's in the center of the screen. Oh my God, he's such a giant man.
His name should be in the Guinness World Book of Record.
Yes.
To be president of APAS, to be president of Arthroplasty Society in Asia, to be president of Asia Pacific Arthroplasty Society, and Asia Pacific Knee Society.
Okay, sir, and it is 4 p.m. Let you start. Shantanudhar Iman, please you start with you sharing screen, and you please allow Professor Amjad Hossain sir please to say more about this Rami Suryal, Nicholas and the Professor Shahid Noor. Shantanudhar Iman, please.
Okay, thank you, sir. Can you hear me?
Yes, we can hear you.
Okay.
Wait, Shantanu, a little bit. Wait, you are muted now. Wait. Shantanu, unmute yourself, please.
Okay. It's okay? Can you hear me?
Yes, Shantanu, please talk.
Okay. So my screen is also shared by this side.
It is already shared.
Good evening, everyone. Respected panelists and dear participants, welcome all of you our today's webinar on behalf of ABC of joint replacement. Today again we talk about basics of total hip replacement and sorry. Yeah. So our mission of ABC of joint replacement is to properly educate the orthopedic surgeons who are interested in joint replacement and thus allow to improve the skill of the surgery and reduce the complication related to the joint replacement. As Bangladesh is a medium income country and there are more than 1,000 orthopedic surgeons and most of some of the orthopedic surgeons are related with the joint replacement surgery, and they are trying to improving their surgery by different means. That's why this is our mission, to properly educate the young orthopedic surgeons and other orthopedic surgeons to improve their skill as well as to reduce the complication of the surgery. So today we have 3 topics. One is about THR templating for reproducing the limb length and offset. And second talk will be on surgical approaches of total hip replacement. And third talk will be on acetabular cup positioning in total hip replacement. Okay, so all of we do the total hip replacement surgery, but before doing that, we have to know about the what is the proper placement of the, or what is the proper choice of the implant. How do we template it before doing the surgery? What surgical approaches is suitable for that patient, and what will be the exact position of the implant for that patient. So these very 3 important things we will discuss today. So fortunately, we have a very expert panelists today from different corners of world, especially from Asia Pacific region. So let's introduce themselves. First of all, we have find and say Professor Rami M. Sorial, FRS SCS and FA Ortho A. Dr. Sorial is from Sydney, Australia. He was trained in Sydney and completed his fellowship from Royal Australian College of Surgery in 1993. And he undertook subspecialty training from Phoenix and Boston. And further, he trained in London by the time of 1996. Currently, he is the head of the department at Nepean Hospital in Penrith, with appointments also to the Nepean Private Hospital and Macquarie University Private Hospital. His academic appointments include, he is the adjunct associate professor of surgery, Sydney University. He was also awarded a visiting professorship through Sichuan University for his work in West China, Chengdu. He was the past president of Asia Pacific Arthroplasty Society, and currently he is the scientific chairman of Asia Pacific Arthroplasty Society. I am welcoming Dr. Rami M. Sorial. Welcome, sir, today's webinar, sir. The second man, who is the godfather of arthroplasty, Professor Nicholas C. Budhiparama, MD, PhD. So he is the founder and chairman of Nicholas Institute of Constructive Orthopedics Research and Education, Foundation for Arthroplasty and Sports Medicine. He is nowadays in Jakarta and Indonesia. So he is the founder, godfather of ISACO's Global Connection Campaign. He is the board of director of and executive committee member of ISACOS, and as well as he is the president of Arthroplasty Society in Asia, Asia Pacific Knee Society, Asia Pacific Arthroplasty Society, that is APAS. And he is also chairman of the knee section of Asia Pacific Orthopedic Association. And he also highlighted the chair, that's the global chair for ICJR, that is the International Congress for Joint Reconstruction. He have also done his fellowship in different areas of the world, that is from San Francisco and from Paris, France, and also from Germany. He also worked with Professor Chittaranjan Ranawa as a visitor fellowship once upon a time, and he also took other fellowship from different parts of the world. Welcome, sir, to today's webinar. A very much warm welcome to you, Professor Nicholas C. Budhiparama. So next of all, we have Professor Syed Shahid Noor, with MD FRCS. He is the president Pakistan Arthroplasty Society and past president of Pakistan Orthopedic Association. He is nowadays the director of Pakistan National Joint Registry, and nowadays he is the head of the Department of Orthopedics in Liaquat National Hospital and Medical College, Karachi, Pakistan. And he is also an executive member of the Leadership Group Pakistan for Asia Pacific Arthroplasty Society. Welcome, sir, Shahid Noor, sir. And the last of all, but not least, Professor Dr. Amjad Hussain from Bangladesh. He is the arthroplasty and trauma surgeon and executive committee member of Arthroplasty Association of Society Arthroplasty Association of Asia Pacific Arthroplasty Society, who is a leadership group Bangladesh, and he's past president of Bangladesh Orthopedic Society, and he's nowadays working as a chief consultant in Department of Orthopedic Surgery and Arthroplasty Center at Lab 8 Hospital, Dhaka, Bangladesh. He's the former head of the department in orthosurgery at Dhaka Medical College Hospital, and he serves at different institutions for different times in different periods. And he's also an non-operative education coordinator for AO Alliance Asia Steering Committee. Welcome, Professor Amjad Hussain, sir. Today, we have three keynote speakers. First of all, the topic is THR templating, reproducing the limb length and offset, which will be deliberated by very renowned arthroplasty surgeon of Bangladesh, Professor Dr. Muhammad Hassan Masood. He is the professor and head of the department in Sir Solimullah Medical College and Mitford Hospital, Dhaka, Bangladesh. Welcome, sir, today's webinar. The second topic, that is surgical approaches for total hip replacement. It will be deliberated by another very much renowned arthroplasty surgeon, Dr. A.T.M. Zulfikar Rahman. He is the assistant professor, Bangladesh Medical College and Hospital, Dhaka, Bangladesh. Welcome, Dr. A.T.M. Zulfikar Rahman, today's webinar. And lastly, the acetabular cup positioning in THR, very much important thing, is a very much young, will be deliberated by young orthopedic arthroplasty surgeon, Dr. Javed Jahangir Tuhin. He is the assistant professor, Chittagong Medical College and Hospital, Chattogram, Bangladesh. And I will be with you as a moderator, Dr. Shantanu Imon. I am working as an assistant professor at Jalabad Radiographic Medical College and Hospital. So, dear participant, by the course of time, you will be muted when the lecture is delivering. And if you have any question or any query, please put your question onto the chat box. Thank you. Now I am requesting Professor Amjad Hussain, sir, before starting the session, to say something.
No, thank you, Shantanu Imon, and all the participants from Bangladesh and all the our beloved and very distinguished guests from abroad. Particularly, I'm so happy to be up to today with Rami Sorial. With Rami Sorial, you know, Professor Rami Sorial is from Sydney, Australia. He's a giant. I mean, he has got all the mind to, develop this arthroplasty in our region, in Asia Pacific region. And I made him in several places, even in Egypt, in Cairo, in India, in Thailand, in where not. And so he's the main thing I like to say you that he's the backbone of this society of APAS. And now we need to join these people, particularly him too. And I would request him so that he can, steer the whole arthroplasty in our country too, as he has developed in other region, in this region. And next, he is the scientific chairman, in the Bali conference from 18 to 21st of August, I think, in Bali Convention Center, and where he is the scientific chairman. So I would request you all our participants to submit the abstract, and so that a big number of delegates can join. If the situation permits, that's the main thing. So again, thank you, Rami. You have joined us. You had a mind to come over here and to help us in developing this subject in Bangladesh. Next is Buddhi Parma, Nicholas. Nicholas is himself is a godfather. Nicholas, I think you can't remember me because that time I was, and my one colleague, Dr. Parvez, with me in your Joe, Jakarta. That was Rami was also there, Shahid Nur was also there. You had a beautiful, and you see this is my shirt, it is from you, it's from Joe, Jakarta. So you understand how much I like your place and I like your clothes. Particularly this sort of colorful clothing is so nice. So you were the mentor of many things. So next you have got the, I mean, I met you in different places too, in Johor Bahru. Last time, I think 5, 6, 7 years back. And then also in Thailand, in different places. So we need your help. We need your cooperation so that we can develop. And Shahid Noor is also our good friend. He was with us in, a few weeks back with this webinar. Regarding my country, I like to say you a little bit because as I was the president of this Bangladesh Orthopedic Society 4 years back, and what our moderator said, actually now we have got around 1,600 orthopedic surgeons in Bangladesh. You'll be surprised to know that when the Bangladesh was liberated in 1971, there was only one orthopedic surgeon who was working in Dhaka Medical College, where I was the student and I became the professor ultimately and retired from there. So now we have got total 1,600 plus orthopedic surgeons in this country of 160 million people. It's a big, huge population, although we have got a small land. And as the development is there, so we need to develop this subject. And we have got the subspecialty now almost everywhere. We have got a big institutions in Nitor, which was initially started in 1972 by our father of the nation, Bangabandhu Sheikh Mujibur Rahman, and he invited Dr. Ronald Joseph Gast, an American surgeon, actually who trained me, who took me to his country also in America, and ultimately, initially it was general surgeon, general surgery, general orthopedics, doing everything, but now Nitor, the name has been changed to Nitor, which is called National Institute of Orthopedic and Traumatology and Orthopedic. So this is the institution where 1,200 bedded, on 1,000 bedded hospital, and almost it is going to be. And but the thing is, so big hospital, very difficult to manage also. But we have got the other private medical college. There are about 100 medical colleges, and we have more than 100, and we have got around 110,000 total doctors in Bangladesh now. And so we are processing. We have got the hand surgery. We have got the the pediatric orthopedic surgery. We have got this trauma. We have got the spine surgery. And so arthroplasty is working, and a few of our colleagues are doing a lot. So we need your help to promote it. So thank you all for participating. As we had the mind that we would be having it in March 2020, but we couldn't do. Rami was very much, was trying to bring a few, pre-orthoplasty surgeons from Saudi Arabia, from different places, but ultimately it was failed. And now today we had the luck that we could make it possible. And I'm so grateful to the God and Allah that at last we could have joined you people in this August gathering. So thank you very much again for allowing me to talk a little bit. And I would request the moderator again to go back. So thank you so much, Rami, Nicholas, and Shahid Noor. Thank you.
Thank you, sir, for your valuable speech. Now, I'd like to start the webinar. And first of all, I'd like to request Dr. Professor Hassan Masood, sir. Professor Hassan Masood, sir, can you start by sharing your speech?
Am I audible?
Yes.
Yeah, audible, and your slide is also shared.
Thank you, Dr. Shantanudhar Imon, and very good evening to the audiences and honorable a panel of experts who are the international orthopedic legends and also arthroplasty legends. So I'll be talking on total hip replacement templating, reproducing limb length and offset. So the learning objectives. After this lecture, we'll come to know what is templating and emphasize the importance of templating and reproducing the limb length and offset. And it will be described the basic principles of acetabular and femoral templating and adjusting the limb length and offset. So first of all, the pre-op planning. Why? To restore the hip biomechanics. And how we can do that? We have to restore the center of rotation in all axes. We have to equalize the limb length and to restore the femoral offset. And successful pre-op planning consists of careful history, meticulous physical examination, radiographic evaluations, and careful templating. And what is templating? The process of anticipating the size and position of the implants prior to surgery. And not everyone does it. Why? Because sometimes it is lack of training and sometimes also for time. To save time, some surgeons do not do the templating, but it will be done always. It is well worthwhile in all cases. It speeds up surgery, precision of surgery, and helps surgeons to avoid many unexpected problems. It is especially critical in complex cases. Helps surgeons anticipate a special implant or instrumentation needs so they can be available at surgery. Helps surgeons identify technical challenges to work out solutions before surgery. And sometimes, especially in the childhood hip diseases, can lead to radiographically subtle but practically challenging deformity because there is excessive antiversion, unusual offset, shortening, malrotation or malalignment, and contracture of the soft tissue. See here this picture. Here it is a DDH cage and there are special components needed. This is a SROM implant and there was a small canal and excessive antiversion, and also there was leg length discrepancy. So to meet up all this need, we have to use the SROM here. And a straightforward algorithm allows optimal implant choice, optimal implant sizing, optimal implant position, optimized hip stability, and optimized leg length. And all the preoperative sizes which are templated should be noted and correlated with the operative findings. A marked discrepancy between the template size and the actual size may indicate component malpositioning, malsizing, or an intraoperative fracture. And here, see, this is a dislocation due to the component malpositioning. And we have to check the pelvic obliquity, range of motion, excessive version, stiffness, flexion, adduction, contracture, leg length discrepancy, also the gait, about the abductor strength, and also we have to check the other joints, especially the spine and the knee. And a 4-step approach for hip templating on a standardized pelvic radiograph. First of all, assess the quality of the radiograph. Second, identify the anatomical landmarks. 3, identify mechanical references. And 4, optimize implant positioning to restore the hip biomechanics. And first of all, the radiograph. Adequate X-ray should be taken. I repeat, adequate X-ray should be taken. And what is that? Anteroposterior orthopedic pelvis X-ray. What is that? You have to take the full radiograph of the pelvis, both hip and upper 2/3 of the femora with 15-degree internal rotation. And you have to take the lateral view, which is also called the Lowenstein view. And sources of error, there may be magnification problem and there may be distortion of patient anatomy. It is crucial to consider the effect of magnification, which is 10 to 20%, depending on the distance of the film and build of the patient. During these measurements, and use of a magnification marker is strongly recommended to minimize the error. See here, it is the magnification layer, the round structure. And now, influence of the femoral rotation on neck length as measured on a radiograph. If you don't take proper X-ray with 15-degree internal rotation, what will be the problem? See here in the first picture in A, the femur position in 15 degree of internal rotation corresponding to the femoral neck anteversion. and the femoral neck is parallel to the film, and a correct estimation of the femoral offset can be made. The projection of the lesser trochanter is 2.3 plus minus 3.1 millimeter. But in B, the femur position in neutral position. So here the femoral offset is underestimated and the projection of the lesser trochanter is broadened. And C in C, the femur position in excessive internal rotation. So here the femoral offset is underestimated and the projection of the lesser trochanter is narrowed. This is also clear in these two X-ray. And now about the X-ray planning. You have to plan the X-ray by taking the index lines. Like here, see, this is the ischioischial line. There are also other lines like interteardrop lines and other lines. You have to measure the leg length discrepancy. You have to measure the lesser trochanter center distance, which is also called neck length, and the offset and the templating and acetabulum. You have to maintain the inclination and center of rotation, and for femoral also neck cut and offset. And first of all, identification of the landmarks. The first step is to identify the bilateral teardrop base. See here, these are the bilateral teardrop base. Then proximal edge and most medial part of the lesser trochanter. Then tip of the greater trochanter, center of femoral head and subchondral bone at the acetabulum and the calcar. These landmarks are easily identifiable intraoperatively and thus help correlating the preoperative information during the actual surgery. The teardrop, here is a red arrow, and the teardrop is the most consistent landmark on the epiview of the pelvis. Leg length discrepancy is measured of the ischioischial line to a fixed point on the lesser trochanter. See, this is the ischioischial line, and this is the point in lesser trochanter, most medial part of the lesser trochanter. So two sides, the difference in the length will be the leg length discrepancy. And another method also there, leg length discrepancy may be measured of the inter-teardrop line to a fixed point on the lesser trochanter, often the most medial point. See here, this is the inter-teardrop line, and this is the most upper part of the lesser trochanter. So here, see, it touches the line, but it doesn't touch the line. So there is a discrepancy. And here also, see the shortening. It is about 1.2 centimeter. And now neck length and offset. The vertical height, which is also called the lesser trochanter center distance, the distance from the proximal edge of the lesser trochanter to the center of the femoral head, which is also called vertical offset. Then the horizontal height, the offset, the distance, it is also called the horizontal offset and medial offset also. The distance between the tip of the greater trochanter to the center of the femoral head. See here, this is the tip of the greater trochanter to the center of the femoral head. And then the femoral neck inversion, this means antiversion, it is also called the anterior offset. And see here the anatomical landmarks, different anatomical landmarks, the femoral shape, greater trochanter saddle, this is called the saddle part, and then the teardrops, this is the teardrop, acetabular roof, etc. And landmarks for radiographic quality assessment, you must assess the quality of a radiograph. It is whether it is oblique or just anteposterior view. So you have to see the foramen obturatum in two sides. See, this foramen obturatum is equal in two sides, and also other things like symphysis, sacrum, distance between the symphysis and sacrococcygeal joint. And you have to see the mechanical landmarks. Like, see, this is the femoral offset, this is the acetabular offset, and other things also. This is the hip rotation center. So the next step is to template the implants. In case of unilateral hip disease, the goal is to match the opposite leg in terms of limb length and offset. If the patient has a contralateral, well-functioning total hip replacement, the goal should be to match it. And see here, the acetabulum is first templated for the approximate component size, position, and to find out its effect on the center of rotation. See here, this is the center of rotation, and this is the position of the cup. The acetabular template is placed just lateral to the lateral edge of the teardrop at a 40 to 45 degrees angle with the inferior margin approximating the teardrop base and the medial border approximating the lateral cortex of the teardrop. See here. And place the appropriately sized acetabular template with roughly 40 degrees of abduction. Inferior border of the cup, see here, the inferior of the cup should be at level of inferior teardrop line. And now, in the contained acetabulum, complete superolateral coverage of the cup with minimal removal of the supportive subchondral bone is desired. However, in reality, there usually is some superolateral uncovering, and this should be measured and correlated during surgery. A 2 mm or 3 mm cement mantle thickness may be allowed for cemented cups. With the cup template in place, the center of rotation of the cup and of the total hip replacement is marked. See here, this is marked here. This is the center of rotation. And now, after the cup positioning in templating, you just make the new center of rotation and calculate the different dimensions, like shortening here is 1.2 centimeter, leg lesser trochanter center distance is 42 millimeter, horizontal offset is 45 millimeter, and cup size is 54. So in most cases, this will restore the anatomic center of rotation. The center of rotation should be compared with contralateral center of rotation by measuring the horizontal and vertical distance of the center of rotation from a vertical line at the teardrop and the inter-teardrop line respectively. See here. And the LLD can then be added to the center of rotation to determine the prosthetic center of femoral head. And portosio acetabuli, defined as the medial migration of the head beyond the ilioischial line or Collar's line, may be present in inflammatory arthritis, osteoporosis, metabolic bone diseases, and post-trauma cases. Careful rimming is warranted in these cases, as usually bone is also softer. Relative lateralization of the cup will be needed to restore the biomechanics and minimize impingement. See here the lateralization. Peripheral rim contact with supplementary screw fixation is desirable in these cases for primary stability. In most cases, bone graft from the femoral head would be sufficient, but severe cases may need structural allografts or cages. If lateralization increases the leg length, a shortened neck with low cut neck cut may be needed. So you have to apprehend all the things in templating so that you can just bring the armamentarium during your surgery. Moreover, asymmetric correction may have cosmetic implications, especially in females in the dysplastic hip. In contrast, in case of dysplastic hip with the less superolateral covering, over medialization with or without superior placement of a smaller size cup may be necessary. And provided that the socket would reproduce the normal center of rotation and there is no substantial deformity on the normal side, the templating should also be done on the normal side for comparative assessment. And now the templating of femur. Templating of the femoral canal and templating done to determine the type and size of the component to be selected, its position relative to lesser trochanter, the level of the neck osteotomy, the width of the remaining calcar, and the selection of the neck length to reproduce both neck length and femoral offset. And see here, it is the templating. Templating should be done in AP X-ray and also in lateral X-ray. And templates are supplied by the manufacturers. And there are also digital templating. I will talk later on. And now, the template is aligned along the anatomical axis of the femur, centering within the intramedullary canal in an anteroposterior field, and is gradually raised or lowered until one of the potential head position is directly over or at least level with the proposed center of rotation. The height and medialization of the center of the prosthetic head is then compared with the length and the offset. See here, these are the measurements. And depending on the type of implant, the size that adequately fill the metaphysis for proximally coated or the diaphysis for extensively coated of the femur is selected. For cemented stems, an allowance of 2 to 3 millimeter for the cemented mantle is taken into consideration. Once finalized, the neck cut is marked and measured from the lesser trochanter. Similarly, the distance from the lesser trochanter to the prosthetic center head is also measured. If the center of rotation has been placed higher than normal, this distance needs to be increased to compensate for LLD. The neutral or slight valgus alignment is desirable during surgery. Lateral radiographs may be templated now to reassess the size and to see if the stem tip is impinging. If the stem tip impinges, options include changing the entry point in the anteroposterior plane, using an anatomic stem, or using a smaller cemented stem. Expected offset can be estimated from the center of femoral head. If it is medial to the center of rotation, the offset would increase and vice versa. Although increased offset aids abductor mechanism, adds stability, minimizes impingement, overcorrection should be avoided as it can lead to asymmetry, trochanteric prominence, and bursitis. Reduced offset decreases the abductor force, increases limb, increases joint reaction force, and may lead to high rate of wear. And see here, a longer neck cut, longer prosthetic neck, and or sitting the component proud will also increase the offset. On the other hand, sometimes an increased offset processes may be required. Coxa cases are at increased risk for limb lengthening without restoring the offset. Options include lowering the neck cut and using a longer neck of using a higher offset, less neck shaft angle, or dual shaft offset prosthesis. The opposite holds true for valgus hips. Similarly, in cases of short neck, like coxra that in Parthi disease, a shorter neck cut with a shorter neck length is required. In doubtful cases, it is better to cut the neck longer and then adjust later on after trial reduction. And see here, this is the hip templating to restoring the original hip rotation center. See here in A, picture A, due to the important femoral head destruction, the original femoral rotation center, this is the original femoral rotation center, FRC, is more proximal and more lateral than the original acetabular rotation center, ARC. This is the ARC. And in the B, see, the acetabular component is positioned in 40 to 45 degree of inclination to restore the acetabular rotation center. But the femoral component is positioned along the longitudinal axis of the proximal femur to restore the femoral rotation center. The lateral overhang and the white arrows, as well as the height and orientation of the femoral neck cut. These landmarks will help to reproduce the exact implant position during the surgery and see the final result after the hip replacement. Based on preoperative templating, Egli et al. Said that is a good procedure to avoid, in many cases, most of the cases, the complications. And now come about the digital templating. With the shifting trend towards the electronic picture archiving communicating system tags, the several soft digital templating softwares are currently available and provide intuitive images analysis and manipulation tools to perform critical preoperative measurements, offset, leg length discrepancy, and also implant selection and placement. The surgeon can select from a collection of templates, different designs from different manufacturers, and electronically overlay them on digital radiographs, which are scaled for magnification. The surgeon can then perform the necessary measurements critical to the templating and preoperative digitally. See here, this is the digital templating. The process is fast, efficient, cost-effective, and provides a permanent archived record of the templating process. Levine et al. Found exact sizing accuracy of digital templating in 73.1% of cuffs and 44.1% of the femoral components in 96 stages, mostly uncemented. And this accuracy increased 98.3% and 88% respectively when +1 size was considered and to 100% with +2 sizes. So another method in case of dysplasia to do a computerized tomographic scanning. The femoral neck antiversion influence the interpretation of femoral offset in plain X-ray. So the take-home message: estimate correct size, shape, and position of the implant, restore the femoral offset, recreate the hip center, set target for leg length restoration. How? By templating. You must do templating before your surgery. Thank you very much.
Thank you, Professor Hassan Masud sir, for your nice presentation about the templating of before doing the THR. So one thing is important, that is optimization should be done for our optimization of the surgery. Proper templating should be done before starting the total hip replacement. So we have some question in the chat box already. Okay, so the first question I would like to ask to our speaker, that how can we correct the limb leg pre-operatively? Professor Hassan Masud sir.
Yes, we can correct the limb length preoperatively, and also not correct, we have apprehend to correct the limb length preoperatively. So what is that? You have to just chalk out the center of rotation of the femoral head, center of rotation of the acetabulum, and finally the center of rotation of the hip. And during the acetabular templating, you just find the center of rotation of the acetabulum, acetabular rotation center. And then when you do femoral templating, you find the femoral center of rotation of the femoral head, and see the discrepancy. Suppose the acetabular center is below and the femoral center, due to proximal migration, it is above. So you just measure the length. See, it is about 2.5 centimeter. And also during the physical examination, you have to see the apparent lengthening and true lengthening or shortening. So during the leg length discrepancy, during the pre-operative physical examination, like when you see from your anterior superior iliac spine to medial malleolus, you can find, and also you see the femoral component and the tibial component, and suppose you find 2.5 centimeter discrepancy. So by physical examination and by templating, we can measure the leg length discrepancy. So we have to plan in the mind that during perioperative procedure, we have to correct this lengthening or shortening.
Thank you, sir. I think Dr. Rami Suriel, would you like to add something regarding this thing about how can we correct the limb length preoperatively?
Can you hear me now?
Yeah.
Yep, good. Firstly, can I congratulate Dr. Hassan? That was a very comprehensive and a very nice presentation covering many facets of templating and adjusting for offset leg length discrepancy. And look, it is a very important aspect of preparing for surgery and proceeding with a total hip arthroplasty that we do template beforehand, whether it's done a week before or even an hour before the surgery. But preparation is the key to a good outcome for your patient. In a standard patient that we see day in, day out, that templating can be done just while the patient is being put to sleep, because you're using generic implants and your average sizes will be available. What you need to understand, however, is your unusual patients or your extraordinary pathologies, your dysplasias, they need to be templated well before, because they're the ones where you're going to need potential prostheses that are not on the shelf. And the more prepared you are in advance of surgery, the better the outcome for your patient. So that's where you'll keep templates in your consulting rooms. And when you see an unusual case come through, they're the ones you'll template in the rooms for good preparation for that patient. Why do we bother? Look, leg length discrepancy, as you're aware, is one of the most litigious outcomes in terms of a patient's satisfaction. So you've got to get the leg lengths right. And how do you prepare for that? One thing to note is that, and this is Dr. Hassan has covered this well, is it's not just the leg length discrepancy you see radiographically on the x-rays as they present. You have to ask the patient whether they feel short, whether they're functionally short, and then do a clinical assessment of the leg length discrepancy, because their shortening may not in fact be coming from the hip joint. They may have post-traumatic results from a fractured femur or fractured tibia. There may be congenital problems lower in the limb that you're not seeing on the basic x-rays. So you have to make a functional assessment of what the functional shortening is in that limb and exactly where that leg length discrepancy exists. And if it is in the hip, then you've got a good chance of correcting it. But if it's not coming from the hip joint, you have to flag that with the patient so that they're still satisfied at the end of the procedure, because you cannot make up for shortening of the femur by simply doing a hip replacement. You can make some adjustments, but at the end of the day, your tension on the abductors has to be correct, or you'll end up with either an abductor insufficiency, or you'll over tighten it and end up with pain over the trochanteric region, as Dr. Hassan has very well indicated. So they're one of the keys to preoperative assessment, is your clinical examination in preparation for the surgery, and then the templating, which I can't add to much more other than what's already been very nicely laid out, except for one thing, and that is if you have severe arthritis, it's all very well to say to the radiographer, please internally rotate 15 degrees, but you know if they've got a severe arthritic joint or if they have significant protrusio, you're not going to be able to develop the ideal position. And if they have that bilaterally, again, you're not going to be able to develop the position for appropriate templating. So there will be a bit of guesswork in that. Now, some of you have seen also the transition, as we've indicated in this presentation, to digital radiographs. This transition has been difficult because, as you've seen from the template that was shown, the magnification on that template is 120%. Some are 115%. So you have to check the magnification and you have to match that with the magnification given on your analog x-rays if you still get them. But if your hospital has transitioned to digital radiology, that's the difficult situation where the magnification provided by the radiographer may differ from patient to patient. And whether you have an AP pelvis in a landscape view or a portrait view in the production of the film will make a difference to the magnification for that patient. Putting a marker on there only helps to some extent because your templates are fixed at 120%. Now, if you have digital templating on a screen, that's good, but there's a cost associated with that unless you happen to be using a specific prosthesis. But certain softwares like TraumaCAD, etc., will give you that facility, but it does come with a cost. So bear that in mind, that if you're transitioning to digital radiology, there may be discrepancies and you could be out by 2 or 3 sizes. So just be careful when you're transitioning over to that sort of technology. Thanks.
Thank you, sir, for your very kind info and valuable information. Moving to next question. The second question is about from Lieutenant Colonel Abdul Kader. He's from Central Africa. Would you please tell us about the templating in dysplastic hip? Professor Hassan Masood, sir. I think you have mentioned it. Can you just summarize something about dysplastic hip?
Yes. In dysplastic hip, there is actually there are types of dysplastic hip, Crowe type 1, 2, 3, 4, and the most important landmark is the teardrop. And if you can find the teardrop, you can assess. But I think I would transfer it to Dr. Shohid Nur for a beautiful answer.
Thank you very much. I agree with the presenter that you have to assess the patient preoperatively. And I would stress that check the pelvis and check the spine as well, because the problem might be scoliosis of the spine and there might be fixed flexion or abduction problem. So the hip problem the soft tissue problem can be resolved through your operation, but the spine problem cannot be. Now, once you have templated, you have set where your center of rotation will be. So you have to look at different landmark, and you don't want to ream the false high acetabulum. So you have to find landmark, and the most important landmark is your cotyloid fossa and the transverse acetabular ligament. Once you are able to identify that by putting a Homan underneath the transverse acetabular ligament, identify the ligament of the head of femur, and there might be osteophyte inferiorly as well, and you might not actually see the cotyloid fossa. So the initial reaming is not medially, it's more inferiorly until you are able to see the soft tissue, and then you have to remove that soft tissue from the cotyloid fossa and see the base. And this is where on the x-ray you identify the teardrop. So that's the basic landmark. And if you are able to put your cup at the inferior margin is your transverse acetabular ligament, then you make sure that your acetabulum is not put higher. You have to see the depth of your acetabulum as well. So the base of your cotyloid fossa should be the maximum depth that you are going to go, but that's preoperative planning as well. And then preoperative templating, for example, you anticipate that the superior lateral bone loss is there, and you have to plan how are you going to cover the superior lateral bone loss. You have two options. You can use the head and put a screw, or you can use a trabecular metal augment. Um, so these are the planning. And for the young surgeon, you have to decide, is it a simple hip with equal leg length and mobile hip, or is it a difficult primary, and what is the level of your surgical skill? Can you solve these issues or you cannot? So for a young patient who has a complex hip, it should not be done by a young surgeon whose surgical skill are not very advanced, because you are going to make a difficult case challenging for the senior surgeon. That's my advice.
Thank you, sir. Thank you, sir. Great advice. So, say a similar type of question regarding the dysplastic hip from the question there is, what are the tips and tricks to restore the actual center of rotation in case of dysplastic hip? May I ask Professor Nicholas Verma, sir, can you give some ideas, sir, about that? What are the tips and tricks about restoration of the actual center of rotation of the hip in case of dysplastic hip?
Thank you. First of all, I'd like to congratulate Professor Hassan Masood for an excellent presentation. It's very clear, you know, the step-by-step A to Z, and after that, all the explanations by my good friend Rami Shorial and Sahid Noor. It is very clear. So the point that I'm going to bring up is for the young surgeons, very important. You have to, before you plan the operations, you have to know the dysplastics, whether it's one side or both sides. If it's both sides, you have to, what side is very, very important point that you have to bring, because you might need another operations on the other side. So this is very important point. And all the points are being taken by Sahit and Rami. But other thing, if you look at my good friends, Larry Dorr. So before, if you look how he do the pre-op X-ray, he also do an sitting and also a standing X-ray. It's very important. Why? Because what Professor Said Nur said, that if you have a fixed lumbar, and when you sit, it is the inclinations and the versions is different. So that you have to consider as a young surgeons, that you have not an anteversion of the femur itself or the cup itself, but it has to be combined. So that what we call it anti-inclinations. This is very important to know, because the angle at the anteversion is different when you sit and when you stand up. So there's another point that have to be taken. The rest is already explained so clear. I think that is a tip and tricks for the young surgeons. And especially, number two, what I'm going to advise is that for the young surgeons, if you look at Professor Hassan Masood, oh, he said he operated more than 300, 400. He doesn't need sometimes to have a templating because, you know, he's daily. But then for the young surgeons, is somewhat very, very important. This is my, my message for them. Yeah.
Thank you, sir, for your good point. Another question is from Muhammad Musa. So how templating help to prevent excessive femoral introversion? So again, may I ask Professor Nicholas, how templating help to prevent excessive femoral introversion?
For a bipolar?
I think he's for the, he's not mentioning it. Okay, we can take it as a in THR, or we can take it as bipolar.
No, I mean, if it's bipolar, it's different. I mean, you know.
He's not actually mentioning what type of you like to ask, but if we consider that thing, I think we can consider both this thing in case of bipolar and in case of total hip. We can, what are the?
Yeah, it's a good question. Of course, it's as a bipolar, you know that it's only the femur side that you have to know the antiversions, which is, you know, what is quite normal. I don't see it on your X-ray, Professor, and your presentations, maybe Professor Hassan Masood. And is that the question now? Is that different between the Caucasians and the Asians? That's number one point. I'm going to bring it. Maybe I can ask Said and Hassan first.
So in the dysplastic hip, there are two problems. One is in the acetabulum and one is on the femur side. You might have a coxa valga and you might have excessive femoral antiversion. So as has been said by Professor Rami, that the purpose of templating is that is it a simple hip and you would only require primary implant which are available on the shelf, or will it require a special implant or different site which is not routinely available? Will you require a standard femoral component, or would you require a modular femoral component which will give you option of change of offset and which will allow change of antiversion and retroversion? So templating will tell you, because a standard uncemented femoral stem will not allow you to change your antiversion. But if it is a modular, like one of the case of was shown with S-ROM femoral component, where there is a metaphyseal sleeve, then you have the option of fixation on the basis of metaphyseal sleeve proximally, and then you can change the antiversion and retroversion accordingly. For example, in a child with a DDH, young child, the people who do open reduction, they change the antiversion. So there are derotation, so there is pelvic support. So similarly, in a dysplastic hip, you can change the excessive antiversion, but then you will require a modular implant. So the advantage of templating is that you decide preoperatively so that there should be no surprise at the time of operation.
Oh, I thought the questions is that how to get you by the templating, you know, the antiversions, and what I'm going to bring up is that the antiversions between the Caucasians and the Asians. That's what I think the question is. So it is my question. Is it that difference? Of course, it's different, right, Professor Noor?
Yes, I agree.
I think that is the question, no?
So there was a bit discrepancy in the question, but I've tried to clarify what I feel, because obviously the Asian's anatomy is entirely different, and the Caucasian and the North American anatomy is different. But the main purpose of preoperative examination and templating is it a simple mobile hip which can be done with a standard range of implant, or will it require a different technique of surgery or a specialized implant? So anticipation and planning. So lack of planning is planning for failure. Failure of planning is planning to fail.
Very important. Yes, it's very important. Yeah.
Can I just add something,
Yes, yes,
if I may, Dr. Iman? And that is, I also got the impression from the question how to avoid excessive femoral antiversion. And the difference there is whether you're using a cemented or a cementless implant. If you're using a cementless femoral component, it is really dictated to by the anatomy. And if you broach correctly, you got to follow within 10 degrees the natural version of the femur. If you're using a cemented femoral component, you've got a lot more freedom by undersizing the femoral component to rotate it into a different position. So keep that in mind when you're actually selecting your implants as to the morphology of the proximal femur in that patient and what you actually want to deliver. If you've got a dysplastic hip, as has been advised by Shahid, then you're not going to be able to use a standard implant for that because of the excessive femoral antiversion. So by rights, you really are either going to use a cemented implant, but if you're going to do a shortening osteotomy, that is a lot more difficult. So what Dr. Hassan showed with an ESROM is really one of the ideal modular femoral components that allows you to fix with a metaphyseal sleeve into whatever version the natural femur is, and then rotate your stem to the most stable position in terms of version selection for your overall construct. So you've got to make those choices preoperatively and have them available at the time.
Can I have a question? I mean, a query to Shahid Noor. How much is difference between these Caucasians and the Asians? I mean, and another point is this, because they don't have this, they get, I think, seldom our dislocation, particularly in child, which we are getting here a lot in our region, in our third world countries. So what is your opinion about this? Yeah.
Dr. Amjad, thank you very much. You see, in the part of the country that I live in, we have extremely low incidence of primary osteoarthritis of the hip. In UK, where I was trained, it was 50% hip OA and 50% knee OA. But here I will see 1,000 knee OA and 1 primary OA of the hip. So the total hip that we do are for AVN, for DDH, for secondary reason. So most of the primary hip that we do are not simple primary hip, they are already complex hip. So it is a failure of fixation, for example, neck of femur where the screw has cut out and AVN or DHS cut out. So AVN is very common. Sickle cell is not very common in Pakistan. So the anatomy is different, but then you have to look at 2 anatomy. One of the acetabulum and the femur. Femur, according to door classification, and see the antiversion and anticipate problem. So it's a combination of physical examination and templating that will stop you from a difficult situation during the surgery.
This is the comment from our Nicholas. Nicholas, how much case you are getting in your part?
Yeah, it's almost the same. What Professor Said Noor said, it is quite pretty but different, because I'm a professor in Holland and in the Netherlands. This is different than the patients in Asia, and especially also if you look at the neck, the configurations of the neck is the form is like more S form. So that you have to consider, because most of the implants is designed or made in United States or Europe. So that is different. I think Professor Rami Sorial has also some research on it, I think, right? Rami, you did some research on the special,
Yeah, but what we see in our country, 90% of the hip replacements I do are osteoarthritis, primary osteoarthritis. The remaining 10% are a mixture of osteonecrosis, occasional dysplasia, it's very rare, inflammatory arthropathy, and then post-traumatic arthritis. That's really the makeup. So it really is OA for the majority of cases. So there is a difference in presentation between countries. The other thing to introduce is the fact that we do see certainly a selection of display or DDH here in this country. However, the screening methods here are so intrinsic in the perinatal period that all these cases are picked up early and managed. So to see someone present in their late teens is very, very unusual. They've all been managed very early on. And I think that is what makes the difference. It's not so much that it's more prevalent, it's just that it's screened and picked up early and managed early.
Right.
May I ask something, Professor Sarantu?
Yes.
How many of the panelists, how many of you panelists do that what Professor Saidnur being said and Larry Dorr, he always make a pre-op, an X-ray from the lumbar and the hip in the standing positions and the sitting positions. What do you think? Is that can be as a standard, or you say no?
So I might start with that. So no, it's not a standard for me. As a matter of fact, I haven't done any, but there is a software program associated with the implant we've designed called the OPS system, which you would have read about, because it's one of the first systems out there that actually marries the spinopelvic balance process to the selection of the acetabular component and its position. And utilizing a patient-specific guide allows you to put the acetabular component in the right position for that patient based on sitting and standing films. I haven't started using that, but I have done a couple of them really in instability in revision cases just to see what the program is telling me. And if we finish in a timely fashion, I've got a few examples to show later that dictate the problems you have when you have poor spinopelvic balance. I've got a very good case discussion to show you later.
Okay,
but I don't use it routinely.
Okay, let's go. Proceed.
There is last only one question left. What is the media importance of medial offset? Dr. Rami Serial?
Look, the offset is really critical for stability and to improve the abductor mechanism so that you have a much more rapid return to normal function. If you don't restore offset, they're the patients who limp for a lot longer in the perioperative period because they'll have abductor weakness and they'll have that mild Trendelenburg gait. So templating, as Dr. Hassan has shown us, is very important to selecting the correct implant. He also mentioned dual offset. Dual offset allows you to deal with the patients who have a higher offset by selecting the right implant for those patients. Now, if you were to measure the average offset, I would tell you that in a Caucasian population, the average offset would be somewhere between 50 to 70 millimeters. But I haven't measured in an Asian population, but I would guarantee you it'd be a lot smaller. So having a dual offset system is very important in selecting the one that matches the patient to optimize their abductor function postoperatively.
Right.
Okay. Thank you very much, Dr. Rami Serial. I think we can go for our next presentation. Dr. ATM Julfikar Rahman, the second presentation about the surgical approaches of THR. You can mute by yourself. Yeah.
Can you hear me?
Yes, yes. You start sharing your screen, please.
Can you see my template? Yeah. See my template?
Screen share karo.
No.
Screen share karo.
Okay, yeah. Yes, your screen is shared.
Go on.
Okay. Respected my teachers and honorable panel of expertise from abroad and viewers, Assalamu alaikum and good afternoon. My topic is surgical exposure for total hip replacement. I am Dr. A.T.M. Zulfikar from Bangladesh. My learning object of this topic is surgical anatomy of hip, surgical approaches to hip, and comparison of some approaches of hip. Before going to my approaches, I just tell one thing about the goal of the THS. What is our goal of THS? THR or THS, biomedically sound and stable hip joint by restoring of normal center of rotation of femoral head. It is most of the achievement done by surgical intervention. Now I go my topics, surgical anatomy of the hips. Hip joint is the largest and most stable joint, and second weight-bearing joint, and synovial articulation between the femoral head and acetabulum, and designed for stability over a wide range of movement. Articular surface of the hip joint is lunar surface of acetabulum, spherical head of the femur.
Zulfikar.
Yes, sir.
Zulfikar, please stop.
Sir.
Probably you are using double device. Please you keep one device mute and the volume is of the volume. Okay, and by which one you are saying? You keep only this one. Otherwise, it is producing echo.
Yes.
Sir, শোনা যাচ্ছে স্যার এখন?
Yes,
right
now it is clear, please.
Okay, sir. Articular sorry, sir. Sorry for the interruption. Articular surface of the hip, lunar surface of the acetabulum, and spherical head of the femur. Acetabulum, it is a horseshoe-shaped articular surface, and it's dependent by the fibrocartilaginous acetabulum labrum, and also there is a non-articular part, acetabular fossa, which is lost by pad of fat, and there is inferiorly there is a deficiency acetabular loss that is bridged by the transverse acetabulum ligament. And proximal femur, it is consists of the head, neck, greater trochanter, lesser trochanter, and angle of the femoral torsion we consider in the total hip replacement. Neck is almost 5 centimeter long, and it is 125 to 145 centimeter in adult. And greater trochanter lateral surface is quadrilateral, and medial surface is piriformis fossa is there. And lesser trochanter is conical projection and attachment with the iliopsoas muscle. Femoral angle of femoral torsion, it is long axis of the femoral leg and transcondylar axis of the femur. It is newborn in 30 to 40 degree, and adult is 8 to 15 degree. This is the anterior muscle of the hip joint, which is related in our surgical procedure very much. Anteriorly, most of the muscle is iliopsoas, serratus anterior, rectus femoris, and medially erector longus may consist. This is the lateral group of muscles, consist of the gluteus maximus muscles, tensor fascia lata. Greater trochanter is the prominent bony mark, and where the iliopsoas band is lateral main content. And this is the deep posterior structure. After we splitting the gluteus maximus, we can see the short rotator, piriformis, gemellus superior inferior, obturator internus, and quadratus femoris, with sciatic prominent large nerve. And this is the medial group of muscle of the hip joint, obturator externus, and other adductor brevis, adductor longus, and adductor magnus muscles. This is the diagrammatic picture of the relation of the hip joint. This is the posterior relation, this is the anterior relation, and this is the superior relation, and this is the inferior relation. Posterior relation, I already told, there's a greater sciatic nerve under the gluteus maximus muscles with short rotator muscles is there. And anteriorly, the femoral artery is the main neurovascular structure with femoral nerve. This is the artery supply of the proximal part or hip joint. This is the main artery supply, medial circumflex femoral artery, the posterior part, and lateral circumflex artery is the anterior part formation of the extracapsular ring formation, and head of the femur is supplied by the obturator artery fovealis. And this is the posterior space of the proximal femur artery supply, I already told. And this is the nerve supply. We know in our anatomical knowledge, Hilton's law around the joint, which muscle is supplied the joint is also supply the joint. There is a hip joint, the femoral nerve, anterior posterior division of pterygoid nerve, nerve to quadratus femoris, sciatic nerve, and superior gluteal nerve. So surgical approach to hip before performing a surgery, it is very, very important to understand the anatomical principle that lie behind the surgical dissection. Each approach has relative advantage and also the drawback. Choice of a specific approach for THR is largely a matter of the personal preference or operating surgeon. Ideal approach. What is the ideal approach? Actually, in practice, there is no ideal approach, but good approach can be told, or ideal approach can be told with this criteria, like good access to both femoral head and acetabulum, should have minimal dissection soft tissue, leading to reduced operative time and blood loss, less postoperative pain and early mobilization, least risk of damage to neurovascular bundle and muscle and tendon, minimal risk of infection, thrombosis, and dislocation. And ultimately, we already told there is in practice, there is no ideal approach. It can depend upon the experience and knowledge of the operating surgeon. Internervous plane is the most important part. Dissection should be done by dissecting and separating the muscle between the two nervous plane. Important to understand before surgery, avoid damage and denervation of the muscles around the hip. This is the intermuscular intervals between the used in anterior, anterolateral, and posterior approach. This is the anterior approach, this is the lateral approach, and this is the posterior approach. It is dependent on the iliotibial band. In front of the iliotibial band, anterior approach. Along the iliotibial band, the lateral approach, and behind the iliotibial band is the posterior approach. Muscle splitting. When you go for deep dissection, always muscle is split longitudinally along the line of fiber, splitting down away from the neurovascular junction. This is also diagrammatic picture. This is the posterior approach, southern approach. This is the hip joint. This is the anterior approach, Smith-Patterson approach. Medial approach, posteromedial approach, Ferguson. Anteromedial approach, Ludlow. Posterolateral approach, direct lateral approach, Harding's approach, and anterolateral approach, Boston-Jones approach. There is a list of approach to the hip joint, not only used in the total hip replacement, we can use in the any kind of surgery in the hip joint. Anterior approach, iliofemoral approach is Smith-Patterson, and limited anterior approach. Anterolateral approach is the anterolateral approach to the Smith-Patterson or anterolateral approach to the Boston-Jones. Lateral approach, Harding approach, McFarland, Harris approach. Posterior approach, Austin Moore approach, we can use most of the THR patient in our country, also used in the anterior approach. Medial approach, Ludlow approach, anteromedial approach, also the Gambido. Approach for the THR. Primary, revision, and minimally invasive surgery. Primary, anterior Smith-Patterson we can use. Anterolateral Boston-Jones, lateral Harding approach, posterolateral Gibson, posterior Osborne, medial Ludlow. In revision cases, transtrocatic osteotomy we can use, and minimally 1 or 2 incision we can use in minimally invasive surgery. This is congenital conventional approach to THR. This is the position of the patient during the approach. When we use the posterior approach, patient should be on lateral position. When we use the lateral approach, patient should be lateral or supine position. When we use the anterolateral approach, patient should be lateral or supine position. When we use the anterior approach, patient should be supine or lateral position. This is the, I can discuss some approach, posterior approach. This is the posterior approach. Patient is on the sound side lateral position. Knee and hip is flexed. This is the incision marking extending from posterior express of the femur. It is centered in the head. This is the superficial dissection, skin incision for fascia lata, skin and fascia lata. This is the internervous plane splitting the gluteus maximus muscles. After gluteus maximus muscle splitting, we found the pad of fat, and it can push the pad pad of fat posteriorly to expose the insertion of the rotator. That means the short rotator. This is the short rotator with sciatic nerve is exposed. This is the piriformis, the superior inferior gemellus, obturator internus, and chordatus femoris. After cutting the short rotator, we can guide the sciatic nerve by the short muscles and expose the joint capsule. And inverted T, we can expose the joint and do our desired THR. This is the lateral approach. This is the position in lateral approach. Supine position on the operation table. Incision begin from the 5 centimeter above the tip of the greater trochanter and extending inferiorly as much as possible, which our desired level. After divided the deep fascia in the line of skin incision, split the fiber of gluteus medius above and tip of the greater trochanter and extend incision distally on the lateral space of trochanter until 2 centimeter of the vastus lataris is also split. This is the vastus lataris, this is the gluteus maximus. Sorry. After develop the anterior flap and divided the tendon of gluteus minimus, muscle is revealed the anterior space of hip joint capsule. This is the hip joint capsule. And enter the capsule using the longitudinal T-shaped incision also and perform THR. Another approach is anterior approach. Anterior approach also patient lies on supine position, but under the affected vertebra, a small sandbag is there, and incision is started curvilinear fashion, starting from the anterior half of the iliac crest to anterior superior spine, and again curve from 8 to 10 centimeter for femoral exposure. Identify the gap between the tensor fascia lata and sartorius muscles by palpation, and found there is a fascia covering the sartorius. The lateral circumference femoral nerve is identified between the tensor fascia lata and sartorius muscles. This is the muscles plane, superficial, sartorius is there, and tensor fascia lata is there. Deep internervous plane lies between the rectus femoris and gluteus medius muscles also. Superior glute, because internervous plane, the rectus femoris is supplied by the femoral nerve and gluteus medius supplied by the superior gluteal nerve. Deep layer of the musculature consists of the rectus femoris and gluteus medius is now visible. This is the tensor fascia lata, this is the gluteus medius. The ascending branch of lateral circumflex artery must be ligated before the exposure next to the deep. Detach the rectus femoris from both its origin, anterior inferior iliac span and also the superior lip of the acetabulum. Hip joint capsule is fully exposed, and detach the muscle of the ilium is further exposed if needed. Now, so many surgeon is accustomed with the posterior, and so many surgeon accustomed with the anterior or anterolateral approach. But I already told there is so many advantages and drawback every exposure. So there is a comparative study in posterior versus anterior approach. The anterior approach advantage is low dislocation risk, but short learning curve, minimal muscle damage is advantage, less post-operative pain, swift rehabilitation, surgery in supine position. And advantage of the post-anterior, short learning curve, prevent excellent long-term outcome and little blood loss. And posterior, disadvantage is long learning curve. And preoperative femur fracture occurs sometimes, more blood loss, long duration of surgery is needed, and different approach for revision. But there is a disadvantage, more muscle damage and higher dislocation risks. So this comparative shows posterior and anterior approach, low dislocation risk is advantage in posteriorly, but more dislocation risk is anteriorly, postoperatively. So my take-home message is ideal or good surgical approaches makes good or excellent result in THR. Good surgical approach, both anatomy and surgical steps should be familiar and experienced to the operative surgeon. Thank you.
Thank you, Dr. Tim Zulfikar Rahman, for your presentation. So there are questions regarding this presentation on the chat box. May I ask all the panelists to unmute? Okay. First of all, so this question from Muhammad Musa. So I'd like to ask Professor Shahidul sir, for the beginners, which approach is preferable for THR?
I think
Very basic thing, sir.
Yeah, it's a very basic thing, but it depends where you have been trained. If you've been trained by a surgeon who always use posterior approach, and you do your hemiarthroplasty by posterior approach, do it. I have been trained to do a Harding's approach, and there is a modern turn a technique of using direct anterior approach. So there is no advantage of one approach over another. The purpose of the approach is that you can see the anatomy clearly. I want to see the acetabulum 360 degree, and I want to prepare the femur easily. So my advice for the young surgeon is never attempt to do an MIS procedure in the beginning of your career. So the wound, it heals from side to side. It doesn't heal from top to bottom. So you have to see the anatomy so that you don't make mistake. Number two, any approach that you use must be extendable easily. Okay, so don't try to learn a new approach. Master yourself in one approach and make it perfect all the time. As you become experienced, you can reduce the size of your incision and approach. So incision is something different and exposure is something different. For example, you can use a posterior or Harding's approach, but then you have to learn the technique of seeing the anatomy and the acetabulum clearly. That you will learn from experience, where to put your Homan, where to put your Chandler retractor, and where to put your Steinman pin superiorly, anterior superiorly, and posterior superiorly. These are tips and tricks that you have to learn from experienced surgeons like Amjad Hussain, like your senior surgeon. So this tips and trick cannot be learned by textbook. This is something that you have to learn by hand under the supervision of experienced surgeon. So that's my take-home message. No MIS surgery for the beginners. Use the approach that you are most comfortable with. I use Harding's approach for my hemiarthroplasty. I had used Harding's approach for resurfacing. I use Harding's approach for total hip arthroplasty, and I use Harding's approach for my revision surgery as well, whether it be first revision, second revision, third revision, fourth revision, fifth revision, or sixth revision.
Right.
Thank you.
We used to do the posterior approach. Now all we are converted to Harding's approach. What about Nicholas? What their experience?
Yes, Amjad, it is a very good point that Said bring up. That when you educate, then you have to master on it.
Yes.
I mean, like, I came from Europe. I'm still in the professor in Europe. So in Europe, the scientists in the UK, you do the lateral approach, the Harding. But if you ask Rami, it's just different. But I think most globally, it's being influenced by the American, because most of the American surgeons, they use an posterolateral. Yes. And they thought when when you go to the conference, you say only a posterolateral. So you think that it is, and most of the European, they are more polite. You understand what, like, very aggressive. This is the way, it is the, I'm in the United States like this, so it has to be the world like this. Of course not. So again and again, it's very important. The point that Said brought up is that one, if you are mastered in that kind of approach, then you have to master. Second, it's very important. when you accept a new technique of operations, very important is there is no new thing without any evaluations. Well, I'm going to say, like, direct anterior approach. It was a hype. It was a hype 5 years ago. Yeah. But now, so many complications, and they said it's not even better. So maybe we can ask in Australia, because one of the pioneer of the direct anterior approach is from Australia. Well, Rami.
And you
Thanks,
approach,
Nico.
what is your approach commonly, Nicholas?
Yeah,
what is your approach
the
commonly?
same, Harding, the same as...
Harding, yeah, that's right. Yes, Rami.
Thanks, Ajit. All right, well, look, Dr. Rahman, again, gave a very good presentation that covered the gamut of the anatomy around the hip joint and the different approaches. It was very good. But one thing he said is that there is no ideal approach for hip arthroplasty. Well, I beg to differ. So I will advise the younger surgeons coming up that the ideal approach for hip arthroplasty is the posterolateral approach. And if you're going to learn one approach to do your hemis, your primaries, your revisions, do the posterolateral approach. And if you do the posterolateral approach for a revision, you won't do a second, third, fourth, and fifth revision because you'll get it right the first time. But anyway, that aside, okay, that aside, whichever one you happen to be learning as a trainee, that is the one you will use when you start practice because you're already been experienced in it. And that's the one you should use extensively to develop expertise. It takes a while to develop expertise, and it doesn't matter whether it's the direct lateral Harding, the posterolateral, or the anterior. Use the same one every time for a few years to develop that mastery so you could virtually do it in the most obese patient, the most complex patient, and you can get it right. That's what's more important than selecting a different approach. Now, there is a lot of hype about the anterior approach, and you're referring to Laurie Cohen, who really started the amongst other surgeons. And look, at the end of the day, if someone wants to do a direct anterior approach to the hip joint for whatever benefit is required, then go somewhere where they do it all the time and learn the technique, but spend a year learning it, because you can't learn it from a book.
Right.
You can't learn it from a video. Surgery will only get you so far. You need to actually, one.
Right. Okay.
Learn it over a period of time, then two period of time before you go home.
Okay, thank you.
Thank you very much for all of you for sharing your experience. Just
Next
one
up.
question left, that is, which approach should be preferred for ankylosing spondylitis for doing the total hip replacement? Professor Nicholas.
Yes, thank you, Santana. Of course, as what Professor Said said, if you ask me now, it's a very difficult case.
As well as Amjad also.
And I have to do it. I have to do a posterolateral, then I hang myself. I'm going to send it to Australia. It's my neighbor, Australia. Yeah. No,
Nicholas, Nicholas, you were in New York in that Ranawat Center, right? I was there too. He doesn't even like to know about any approach except
right. They're going to kill you. Yeah, you are right, Hamdi. Yeah. So this is my answer, Santanu.
Okay, thank you.
Yeah, the same.
Thank you. Dr. Rami, do you like to add something regarding this ankylosing spondylitis?
Yeah, now you have to be careful here because unlike other pathologies, you don't have a mobile hip. So it depends on the position that the hip is ankylosed in. So if the hip is, and you've got to do a CT to assess whether your approach is suitable from posterolateral. In other words, are you going to get access? Because if the hip is markedly externally rotated and the greater trochanter is impinging on the ischium, you're not going to be able to access it. So you've got to work out the position of the hip. If it's in neutral or if it's internally rotated, you'll get great exposure from a posterolateral approach in order to make your neck resection, take a segment out about 1.5 centimeters, and the rest is pretty straightforward. But if you're markedly externally rotated, you can start with the posterolateral approach. If you can't get in there, then you're going to have to also swing around from the front using the same incision to make your first osteotomy, allowing you to externally rotate and then take the segment out. So you've got to be a little bit flexible in that situation.
Right.
Thank you very much for your nice comment. I think there is no question in the chat box. We can go for the third lecture, the last lecture. Dr. Javed Jahangir Tuhin, the acetabular cup positioning. Dr. Javed Jahangir Tuhin.
Thank you, Dr. Shantanu, for inviting me for my presentation. It's a great honor and pleasure to have the distinguished faculty from Australia, Indonesia, acetabular cup position in THR, one of the difficult and challenging in total hip replacement. Shantanu?
Yes, your screen is sharing. We cannot see it still now. Just wait. I think your network is has a little bit problem. Internet.
Javed. নেটওয়ার্কের প্রবলেম হচ্ছে রে ওকে হারিয়ে গেল নাকি ইমন শান্তনু
না
হারিয়ে গেল
মনে হয় নেটওয়ার্ক ইয়ে হচ্ছে ডিস্টার্ব হচ্ছে
আরে এটা নিয়ে তো বারবার ফজলু সেদিন বললো যে
শান্তনু
yeah can you no still now it is not share we can
Shantanu, can you see
no screen share.
Your screen is still not shared. What you can do, you stop your video, please. Okay, you just stop your video and just put your screen sharing. Go for screen sharing. You just stop your video. Maybe your internet connection is in little bit trouble.
Don't delay.
Dr. Javed. Sorry. Yes.
তুমি ওই ফজলুকে বলো let us start talking. Javed Shahid Noor will be leaving as he told earlier.
Okay.
So we can discuss just.
So I think we can. Dr. Shahid Noor sir.
Yes.
Okay. Can you hear me, Dr. Tuhin?
Yes, we can hear you.
Yes, Tuhin, return back.
Yeah.
Yes, Tuhin, please
Can
start.
you see my screen?
Yes, we can.
Okay, sorry for interruption. Now I'm going to talk on acetabular cup position in THR. Let's
Sorry for the interruption.
Can you see my screen, Shantanu?
Yes, we can see. Yeah.
So let's have a look in the learning objectives. We have to understand the mediolateral position, that is whether my approach will be conventional or anatomic approach according to the patient characteristics. Determination of the height, thereby limb length and joint reaction force, and recreating the orientation of neck tip acetabulum, the anteversion and inclination, and understanding the relationship with pelvic tilt. So this is the congruous relation between hip rotation center and pelvis and as the cup orientation around the rotation center. So in the right picture, you see the component it plays within the native acetabulum area, and this is good. And in the right hand side, you see the component is not placed within the native hip area, so there is a chance of wasted motion and overlapping of the motion and chance of impingement. Total hip replacement was called the operation of the century. It's the most successful and cost-effective intervention, but it not without complication. Complication like limb length discrepancy, instability, gait dysfunction, impingement, either in the form of bone to bone, bone to component, and component impingement, loosening, wear, and dislocation. And one most important thing which affected acetabular cup position. So our goal is to restore native hip biomechanics and reestablish the global offset, thereby restoring joint function, maximize the longevity of the device, and achieve the stability of the joint. And when we look, we have to look at 5 aspects, that is medialization or depth, height, angular positioning, that is anteversion and inclination, and pelvic tilt. You know, not all are same and not all pelvis or hip the same. So we have to approach as a tailored approach or individualized approach. So what are the challenges? First, the determining the target for that patient and which might be the anteversion of that patient and which might be the inclination. And determining the target, how can we execute it? By preoperative proper assessment of the patient, pelvic and spine relation, and templating the patient. How much I have to medialize and how much coverage I needed. And my target would be the combined anteversion within 30 plus minus 10. So what are the tools available? The alignment guide, the commercial guide that dictate us, and some anatomic point which the transverse acetabular ligament, the posterior remaining labrum, and acetabular notch, and other bony landmark. Sometimes in complex hip, you might need a computer-guided navigation, which help in enormously in case of complex hip. Intraoperative fluoroscopy sometimes needed, and it will help to guide us when we face difficulties perioperatively. So now hitting the target, you must need a 360-degree exposure of the acetabulum. You have to see where your cotyloid fossa, where is your transverse acetabular ligament, and the labrum, and how much coverage you will get. So in the left side, the calf is medialized nicely, but in the left one, you see the calf is very much lateralized and uncovered, and it might face instability and dislocation later on. So in conventional thought, the medialization cup in a smallest, when there is a small structure, shallow acetabulum, when adequate lateral coverage is needed, we have to medialize cup like in dysplastic hip. And for medialize the cup, we have to use the true floor of the acetabulum, and femoral offset must be higher in case to restore the global offset. In anatomic and kinematic approach, the cup is placed just lateral to the collar line, and in when there is a large bone structure and adequate acetabulum, and medialization will make restoring the offset difficult. In that case, you must lateralize. And in uncemented cup, where the cup is press fit using the lateral cortical bone, you must need to lateralize. And tal and labrum is the most important guide to depth and also the length. Another important aspect is the height of the cup to reproduce the native height to restore the abductor strength and joint reaction force, and intraoperative determination of the length symmetry in both sides. And our target is cup should be placed within an area between the teardrop and inferior posterior acetabular rim. Now, let's have a look to the angular position of the cup, the inclination and antiversion. In uppermost left, the cup is too anteverted, and uppermost right, cup is retroverted. And in the lowermost, cup is too deep, and in the right, cup is too high. So ideal position, usually we have to achieve inclination about 40 degree. And radiography inclination is about 42 degree, which is less than operative inclination. And antiversion, our target is within 15 degree, plus minus, it might have plus minus 10 degree. And internal landmark is the transverse acetabular ligament, which will guide us to place the cup within the correct antiversion. So you see in this picture, the cup is too anteverted. Transverse acetabular ligament is proud. And in this picture, cup is retroverted. Transverse acetabular barely seen. And in this picture, you see the transverse acetabular ligament seen clearly, and just the cup is cradled, and it is within the posterior rim and the transverse acetabular ligament, and this is ideal position. So let's not forget about pelvic tilt. You know, pelvic is a dynamic movement. Pelvic movement change the dynamics of hip, and from sitting to standing, standing to sitting, there is a change of relationship pelvic with hip. So there is a change of anteversion and inclination, though inclination affect least. So my take-home message is no single solution for all problem. Preoperative planning and templating are most important. Proper exposure and identification of the intraoperative landmark, absolute necessity. And every hip is unique. Individualized approach is optimum. Thank you very much.
Thank you.
Thank you, Dr. Javed Jangit, for your concise presentation. So far, we have no positioning. So, Dr. Rami Sariel wants to show some of his case. I think
my video off হয়ে গেছে video দেখাচ্ছে যে you cannot stop, you cannot
okay, Dr. Rami Sariel, we would like to.
Yep,
we have some time. I think we can.
I got a couple of cases I'd like to share with you, which really emphasize some of the points made by all three presenters. Before sharing that with you, I'd just like to make a point on this presentation, a very good presentation on the ideal positioning of the acetabular component. However, a lot of those points are really said to us with the intent that you have a normal acetabular shape. However, if you have a significant arthritic process with large osteophytes, you have to be aware that the positioning of the cup may well sit well inside the anterior osteophytes. You often have to resect osteophytes posteriorly and inferiorly if they're excessive. So this is what comes back to templating, because if you template a cup, you will know from the templating the ideal position of the prosthetic implant within the contours of the osteophytes that exist. And then you aim to replicate that after impaction of your acetabular component. And if you see that the cup is sitting more exposed superiorly than what you'd planned for in the templating, then your inclination is too closed. Whereas if you see less of the cup than what you planned on templating, then your inclination is higher than you had expected. So use your templating as a key unless you're going to resect osteophytes. And if you are going to resect them, plan that on the X-ray, how much of those osteophytes are going to be resected, and again, where the cup will sit in relationship to those osteophytes. It's hard without showing you a video to demonstrate that, but take into consideration that not all acetabuli are like a native acetabulum. There's going to be osteophytes present and excessive. So that comes back to one other thing, and that is the positioning of the patient. The positioning of the patient is key, particularly if you're using a posterior approach or a lateral approach where the patient is in the decubitus position. And stability of the pelvis and the positioning of the pelvis and making sure it doesn't move through the process of the operation is very important to the overall alignment for version and inclination of your acetabular component. So make sure you use a good bolster that stabilizes your pelvis throughout the whole procedure and doesn't allow movement. I think that's a very important part of ensuring that you put your acetabular component in the right position. Can you see my screen?
Yeah.
Yes, we can, yeah.
Okay. So look, I've selected 4 cases really from the last 3 weeks because these particular 4 each really emphasize a few points, which I'll go through the cases and perhaps a number of the panelists can make their own separate comments on how they would approach each of these. So the first case, this is a retired dentist, 65 years of age, and he's presented with 3 months of quite substantial disabling right groin pain. And you can see on this X-ray, there's an increased sclerotic area or sclerotic wedge in the superior aspect of the femoral head. And if you look close enough, there may even be a depression in the articular surface, all consistent with osteonecrosis, which was his problem. The interesting part of this history is that this gentleman had his left hip fused many decades ago for Perthes disease. And he actually came to see me about 15 years ago. And 13 years ago, I did a UKA on his left leg using an Oxford cementless UKA, and it's done well and continues to do well despite the excessive forces going through that left lower limb. But now he has a significant problem with his right femoral head and his right hip. He's got a depressed osteonecrotic fragment, and he's got the issues here of a fixed pelvic obliquity because of the adduction deformity subsequent to arthrodesed left hip joint. This is going to impact obviously on stability. It's going to impact on a number of things in terms of biomechanics and the increased forces through that hip. So you have to put some thought into that and how you're going to approach it. There will be a leg length discrepancy, but this is the opposite of what you'd expect simply because he's had a fused hip on the opposite side, and that unfortunately will not change. But because of that fused hip, not only is there a true leg length discrepancy, there's also a marked apparent leg length lengthening on the right side, which is not going to change because of the fixed pelvic obliquity. And that's without even taking into consideration anything to do with his spine. The offset you can see there is quite large, probably measuring in the realm of about 60 to 70 millimeters. So these things all have to be taken into consideration. There's his lateral. This guy's got a history of alcohol consumption, one of the contributors to osteonecrosis, but he's also been on steroids for treatment of fibromyalgia. And so he's got 2 factors that can lead to osteonecrosis. at surgery, this was his femoral head. So sharing that with you, obviously the next film is what I did, but it'd be interesting to have a discussion amongst our panelists as to how they would approach this and whether it would be other than a standard hip arthroplasty or whether they have any tips and tricks that they would like to share in the circumstance of the hip opposite an arthrodesed total hip joint. Maybe Shahid, do you want to?
Yes, can you hear me? So this is a complex hip and the chances of problems are here. The femur is pristine and you've very nicely mentioned about the pelvic obliquity and apparent lengthening on the right side and the stresses passing on the right hip. So the femoral component will be a standard femoral component, but um, I would have a high inclination of using a dual mobility cup on the acetabular side. In future, he might have a problem in the lumbar spine and he might request for a converting the left arthrodese hip into a total hip arthroplasty, and that is going to change the dynamic as well. So if you put a fixed cup in this position and later on convert the left arthrodese, it will, so a dual mobility is going to give stability now and it will give stability if you do a total hip on the left side. That's my thought.
Yeah, and I agree with that, Shahid. So this is the main reason I wanted to present this, in that this is a sort of case where you could use a standard cup if that's all you have available, but you have to change the position of that cup somewhat to accommodate. But if you had access to a dual mobility, that is the best option here. Another thing to consider, because of the fixed pelvic obliquity, is what inclination do you put for the acetabular component? And I would argue that you should put it a little bit higher than usual. Otherwise, you end up with impingement between the greater trochanter and the side of the pelvis. So I've used a high offset femoral component. I put the inclination a little bit higher for the acetabular component. And because of the risk of instability in the forces going through, I've used a dual mobility liner, as you've indicated, to minimize the risk of dislocation. And should he have a takedown arthrodesis on the other side, which is unlikely in this patient, but should that happen, having the dual mobility liner in there with a higher inclination, again, decreases the risk of instability on that side. Anyone else want to comment? Amjad, do you want to comment?
Yeah, I want to comment. You did unicondylar knee for him on the same
on
side?
On the left side, yeah. Left side.
On left side you did. Okay.
Yeah.
So to me, this your inclination is little less. More inclination would have been better, I think, because there is a higher chance of, because this is a completely, obliquity is more on lower side. What you've done. Yeah, this is my comment. And I would request at the same time, I would request him to do the other side, because I don't know, I don't have the experience of, putting one side total hip and then other side is fused. How long it will continue? Yeah, go on.
The other thing to note is by drawing that line, I want to show you that I specifically try not to lengthen him more by using a high offset stem, but leaving it without. So the intent is not to add more length and compound his leg length discrepancy. And you can do that by using the high offset option in this construct. Nico, any comments?
Rami, can I ask you a question? Do you have the options of modular neck? It used to be popular, but is it available in Australia and do you use it?
Yes. So look, I went through a phase of using modular necks with an ABG stem, but unfortunately a number of them have failed, or they've been recalled, I should say, rather than failed, because I've only had one that I've had to remove. But as you know, because of the dual Morse taper, there's been some issues with a number of those implants due to taperosis and metal problems. So I've steered right away from using modular necks in this circumstance.
So theoretically, it gives a lot of advantage that you can change the offset without changing the length, and you can change the length without changing the other way around. But yes, we've had problem with cranionosis and other problem that it has been removed from it's not freely available.
No, no. All right, so I'll go on to the next case. Now, this is just to share with you, again, this is one in the last few weeks. This gentleman, because of COVID, took up jogging on a regular basis for exercise, and he came to see me because he had a fall while he was jogging. He actually presented 6 weeks after the injury. He was able to weight bear with crutches and had a good range of motion when clinically assessed, with only mild discomfort coming from that left hip joint. I show this as an example of a patient who really had a Pipkin fracture of the femoral head that was minimally displaced. It was identified more on CT than anything else. And at the 6-week mark, he had minimal symptoms, and the discussion was whether to manage him non-operatively or to offer him some form of surgical intervention. We chose non-operative management here. Weight bearing is tolerated after 6 weeks, progressively improving range of motion and slowly getting back to a water-based exercise program. Unfortunately, he came back to see me at the 3-month mark, and he completely displaced his femoral head fracture. So now he's on crutches, unable to weight bear, an emergent presentation that required immediate surgery. So this is a case really to show that with a significant leg length discrepancy, it's one thing we haven't mentioned actually in our discussions, and we should, and that is, what technique do you use intraoperatively to record and then balance your leg lengths so you end up delivering what you planned in your preoperative templating? I think that is something we should discuss as panelists. What's your own techniques intraoperatively to deliver leg lengths? Amjad, do you want to start?
Yes, what I do in my case is I don't use pillows or just a sheet, I mean a gown sheet or something like that, so that I can measure it when I'm putting my final, in the head. So before that, by trial, I'm just by knee and by the same length, same position in the knee as well as the foot, and that way I just I have experience of doing it, so I made it. I do it like that. Yeah.
Okay. Shahid, do you have a technique?
Yeah. I have two possibility. One is external, and the other is at the operative side. So I do my hips in lateral position. So the feeling, the other knee length give me intraoperative, and then I put a Steinman pin, not routinely, but in difficult cases, and I put a thread and mark before dislocation, and then when I've reduced, so that gives me how much leg length I have pre-planned and I have achieved.
So do you put the Steinman pin in the iliac crest or in the AIIS?
In the iliac crest.
So extra-articularly?
Yeah.
Okay, good. So that's another technique. Nico, do you have a technique? Is Nico still with us?
I think no.
All right, so
it's not
that's
there.
okay. So look, I use something called a Burns calibrating device, which is basically a conical bolt you put into the iliac crest about 2 centimeters proximal to the ASIS, so you're well clear of the lateral cutaneous nerve of the thigh. That acts as a reference point from which we measure both length to the greater trochanter and offset. And that's done pre-dislocation and in this situation, you've got a fracture, so it's a bit different. You can just do the length. You don't have to do the offset. And then once you do your trial reduction, you put your calibration device back onto the fixed point, and it reassesses your leg length after the new implants are in and the offset. And then you can adjust in terms of getting the calibration device to give you the correct range and adjust that based on soft tissue balance and also the other techniques that have been mentioned, that is putting the knees on top of each other. So you got multifactorial means of assessing to minimize the risk of ending up with a leg length discrepancy. So I would recommend that either use, as Shahid has said, a Steinman pin is simple, it's cheap, it's available in every hospital. You can put it in the iliac crest, put another one in the trochanter, and measure the distance between them prior to dislocation, and then use it again post-reduction to make sure that you are where you aim to be. So this gentleman ended up with a cementless total hip arthroplasty using a cementless cup and a cementless implant. What is notable here is that this gentleman had a mismatch between his metaxial diaphyseal space. It's unusual for me to have to ream the diaphysis, whereas here I had to do a bit of reaming of the diaphysis to get that match between the two. Normally a broach is all I use, but here we had to do a little bit of reaming distally to get a good fit and deliver the prosthesis in the position that I wanted in terms of rotation. So this is really just to make you think about leg length discrepancy and how intraoperatively you're going to deliver the results that you want.
Rami, before going to
Yes.
the case 3, yes, we have treated this patient non-operatively, but could you have put a cannulated screws, and would that have reduced any chances of displacement? Would you have considered?
So when you look at the fragment that came off, right, it's fairly inferior there. So yes, in retrospect, perhaps, I mean, the fact that this happened means had we offered him a form of internal fixation, I'm not sure if a cannulated screw would have done it. This sort of presentation requires really an open reduction and headless screws in order to fix that fragment back onto the metaphysis of the femur. I'm not sure if a cannulated screw really would have secured it sufficiently because of the size.
Yeah, a very small size, very difficult to keep it.
That's right.
Yeah.
So the only way really is to do a formal dislocation and put headless, screws intra-articularly into the fragment to fix it back on. And at 6 weeks, I didn't feel that was justified, particularly as if you look at his original x-ray, he's got arthritic change in the superior aspect of that hip joint. So worst case scenario is, okay, he develops more arthritis, but I must say I didn't expect this picture at the 3-month mark. That's
Right.
very unusual.
Yeah.
Shahid, comments?
No, excellent. Done nicely. You've restored leg length, but yes, the anatomy, and that's the advantage of doing templating, that it is drawer type 1, and you have to see that whether your standard implant would fit in, or you need to ream extra, or you might need to have a special implant which will go to a narrow diaphysis.
So this one I'd like to share with you, just a 75-year-old lady. She presented with groin pain, thigh pain, and leg pain over the past 2 years. Now, to everybody out there looking at this, the biggest clue on this, there are 2 things on this x-ray. One, that the reduction in joint space doesn't look that bad. And 2, that there's a great big screw across the SI joint, which is a warning, particularly when someone has pain that really traverses the whole left lower limb or right lower limb, or whichever side it is. I show the AP and lateral to show that the reduction in joint space is what I would call mild to moderate, and some would argue there's not much there at all, particularly for someone you're considering a hip arthroplasty on. An intra-articular shot of cortisone led to substantial relief of symptoms in the groin and thigh. And after a lot of review and medical reassessment and re-examination, I made the decision to proceed to a total hip replacement. But this is the preoperative film to indicate that this lady has had a number of spinal fusions, but more so, take a look at the fusion of L5S1. The rods on both sides are broken, indicating that it's a failed fusion. If you look at this screw, there's a halo all the way around it. So this patient obviously has a pain generator coming from the lumbosacral spine, as well as a pain generator coming from the hip joint. And it really was a question of, do we proceed with a hip arthroplasty with her having to understand that it may not resolve all the problems that she has, and it may only contribute to some of the problems that we can fix. Now, we did go ahead with the surgery, and this is the intraoperative specimen to show that she in fact had more substantial wear than what was seen on the X-ray. And to her benefit, she's seen an improvement, but she's still got the problem with the lumbar spine. So again, this is a case of a patient who has failed fusion, a stiff spine, an impact on spinopelvic balance. I don't use dual mobility that often at all, but this is another patient where a dual mobility is indicated to decrease the risk of instability because of the spine, and one to show you that there can be multiple generators of pain, and you have to make a valid clinical assessment as to the ability to resolve some of those issues for the patient by doing a hip replacement. Amjad, do you want to comment?
Oh, no, because already she has problem on the back, and it's difficult, and what you did, you should have been done, because I get lot of cases, Rami, here. I did yesterday I did 2 cases of this avian, because I'm getting so many avian in our country in the younger age group, particularly when your case is older. But here I should say, because of her problem in the spine, she would have problems, she would have complained. But what is done is done. It's really, we needed to do it. Thank you for this nice case. Yeah.
Shahid, comments?
No, absolutely agree. I mean, we should not be treating the X-ray. We should be evaluating the patient overall, because this might be a very unsatisfied patient, and you have to do a negative counseling that this surgery might not improve all your symptoms, because some of the symptoms might be radicular symptoms, especially the pain is coming to the thigh and the knee. And I would get this patient evaluated by the spinal surgeon as well, and have a high threshold for doing, but nicely done, and I'm happy that the patient symptoms has improved. Amjad and Rami, I would like to take a leave. I had planned to stay for an hour. I have some another commitment, but if you allow me, then I will take a leave.
Okay.
Thanks.
Thank you.
Shahid.
Thank you very much, and
Thanks,
everybody,
Shahid, so for
all
coming.
faculty from Bangladesh Orthopedic Society, Rami and Nico. Thank you very much.
Thank you. Thank you so much.
Thanks, Shahid.
Thank you very much, Professor Shahid Noor. You've given us time in your busy schedule with a very short notice. Thank you very much.
Thank you very much. Okay.
Thanks, Shahid.
So,
Rami, do you have any other case?
I have one last case, and it's really one last case, really
Rami,
to demonstrate.
I have got a few cases. If you, I mean, your time is already, I mean, you're 11 o'clock now, I think. So if
It
you
is,
give 10 to 15 minutes, then I can show my a few cases.
Okay.
Okay.
Let me show you this one.
Yeah.
And this is just to talk about what we've actually been discussing, and that is this 85-year-old lady presented with a dislocation of a right hip replacement. Now, the important thing here is that she had bilateral hip replacements 15 years ago and has had no problems with either hip joint. They're actually done by a senior surgeon at our hospital, who was the founding chairman of APAS, Dr. Chung. So they were done very well, and she was completely asymptomatic up until 6 weeks before she presented to me. And she presented with the, now how did this happen? Well, we can see here on this X-ray, when she came to see me, I said, what's going on up here? And what I realized is that she had just had a fusion 6 weeks before the dislocation. So with no problem in the hip at all, she had a spinal fusion, and then 6 weeks later in the rehab process, dislocated her right hip. And she subsequently has had 3 further dislocations before I operated on her. And this is what she's had done. You can see she's had cervical fusion, she's had lumbar fusion. And this is showing you that you can have stable hips for 15 years, but you change spinopelvic balance by fusing the lumbar spine, changing the position of pelvic tilt, and suddenly you have an unstable construct on the right side, which required revision. So this is a very good example of how the spine and the pelvis can influence the version of the cup and give you an unstable scenario that requires revision surgery. We did that with an explant, put in another cup with a dual mobility articulation, multiple screws to give her the stability that she now needs in extra antiversion and slightly closing the cup with a dual mobility liner. So this is a good example of spinopelvic balance changing the outcome for a patient. You've always got to take that into consideration. That's it.
Yeah, thank you so much for nice cases. Yeah.
Okay,
Yeah.
thank you. So, I think that's all of our webinar. Sir, Amjad sir, do you like to show something?
Yeah, a few cases, yeah.
We are running short of time.
Can you see, can you?
Yeah, we can
Yes,
see.
sir.
Okay. Some basics of a few cases, yeah. I will just pass through. Rami, I will go through. Yeah. This is a date of 12, so I'm in OT date. But bilateral AVN, which we are getting here, so many cases. We are totally perplexed with this situation. See, very young is 28 years only, you see. So, and 3 months follow-up, and then video is here. But I'm not going to show the video, but this is really a problem.
Yeah.
He's walking, running, but bilaterally done, 6 years follow-up. So another 60 years already, traumatic AVN again. You see the spinal problem was there. And then this lady, yeah. What I wanted to show the cementing. You see, cementing, I think our colleagues should know, our junior should know that cementing is a good, it's a bipolar. The down is not cemented, I think. Yeah, no, but cemented, both sides cemented, yeah. So this is a cementing good. And the follow-up is also good. This is very, another case, 64 years at the time of study, 95. Actually, this was the period when we started Rami, more or less. Our senior teacher, he is an FRCS from England, Professor Ruhul Haq. He started in 80s, a little, not too many cases. And I got something from him, and I started it in 90s. And that follow-up is still, that man is survived, he's still 89 years old or 90, still doing good. This is the cementing. And Charlie, you can see the Charlie stem. And still he's working, he's doing everything. He went for Hajj, Mecca. Yeah, this gentleman. So another Protuso Acetabular is a, you understand, bilaterally, one side is Protuso, another side is AVN again. And this is the situation. This is the mesh is given for him. And the other side also done. But as it was little bit cement was inside. But it's good, she's working. She's 8 years follow-up. And then this is also another difficult case. Is it trochanteric fracture, then DHA is done, and then implant removed, and then you see the very difficult case, and AVN also developed. The head is totally gone, and the OT date in 14. So this was the what I did, and then she is working normally. Again, another case. This is a case 24 years only, male, pain whole body, it is ankylosing spondylitis, as you said earlier. You have got cases. And also psoriatic arthritis he has. This is a young chap. You see, as you said in this, how the version can be changed. And he has this lumbosacral joint angle, which should be around 20, but he has more than 30 to 40, and he has only 20. So in this case, we should be careful about, and you see how the painful is. He's a young chap, you see, but you see here how his knee is fine, but it's still hip is a problem. And putting the cup in the right version is important here, as you told. Yeah. So this is the case, 5 to less degree inclination on the right side, and here on the horizontal on the right. This is another case, very difficult. I mean, 22 years, this gentleman, he couldn't walk properly. He is standing, you see. It's a total bilateral ankylosing hip with fused spine and everything. And you see how his in operation room, the whole body is moving, whole body is moving. Yeah. So whole body, very difficult even for the anesthetist to give him the anesthesia. So this is the situation bilaterally, more vertical on calm on the right side and on more horizontal on the left side. And this gentleman, you see here, after follow-up last year, still he's doing everything. He's sitting, he's doing, and so he's very happy now. So this is what, as you said, I don't want to go through all this. Another case is failed DSS, very common also in our scenarios. So cemented TSR with mesh here, we applied mesh, and then she is walking, the gentleman, and recently he has passed away. He's walking, lame, but still not bad. Painful heavy with broken implant and removal of the. And how do you remove this implant, Rami? Do you have any? Can you share?
Yeah, you'll usually need a very extended trochanteric osteotomy to get to the bottom of that and be able to tap it out with a cold chisel.
Yeah, that's a difficult situation.
Very difficult.
Yeah, I had to go through, and you see, can you see on the right side that that was a small window I made, and then taken out the first this proximal one, the head, and then the distal one, the broken one, and then you see the mesh with we don't have the cable, but we have the mesh with cyclase wire, so and this cemented hip, and I hope she's happy because she's working. You see, she's working normally. That's great. Another case, a long follow-up, because in 1996 we did this 55-year gentleman at that time, and then you see the cemented Charlie both sides, and that the cup is not, and cementing is not good. So by this time in 92 now, still he's working. You see, he's in a market and selling. He's a shopkeeper, and still with this scenario, he's doing his normal life. This lady was done this bilateral again AVN 24 years with non-Hodgkin's lymphoma, and core compression done Bombay, I think, and nothing was changed. So as you shown, this is the scenario of the head. Most of the time, I'm also keeping the head head, and this is the from more or less the whole thing. At this part of the whole head is I mean, particularly this cartilage is gone, so there is no preserving, I mean, method. So this is the situation we are, and can I go back? Yeah, Shantanu, go back. Yeah. So Rami, this is our. So in my country, in our country, you see, we have when we have started our journey by Dr. Ronald Joseph Gast, he's an American. So in 1972, as I told that only a few, I mean, one surgeon was there. And then at that point, at that time, Australia and different countries helped us a lot. And $100 average was below 100 was our per capita income. Now, now it is almost 2,300 I mean, per capita income. So tremendous. I mean, our people are, I mean, getting better and better. And hopefully this, you see, we couldn't believe even to buy this American implant as a European implant. All we are using, as you know, we are using here. And our colleagues, my students, most of them, Masood is Hassan, who just now presented, all are there, my students. They are doing fantastic job. So only they need some exposure, they need some, meetings and some sort of your kind cooperation. So thank you so much for joining this meeting.
It was a pleasure and a very good meeting. Well organized.
Yeah. So we will be again troubling you sometime to go and then to see your cases, more cases on our boys. You see the 3 chaps, they beautifully presented, I think.
Very good. Very good.
Yeah,
Commendations for those presentations, actually. They were very well put together.
And you see, our language is English because our
It's very good.
Yeah, so that is again great help for our presenter to speak. Yeah. So thank you, Rami, so much. And Nicole is not there, I think.
That's all right. He had to retire early. But, you know, hopefully if things work out well in terms of control the COVID, you mentioned at the beginning, the APAS meeting in Bali.
Yeah.
Obviously, it's August next year. There's a lot of time between now and then. And if things go well, we'll be going ahead. If not, we'll organize an online meeting of some sort, one or the other. But hopefully we'll meet together over there and should encourage your group to put in at least some abstracts for presentation. That would be very good.
Okay. Yeah, we would be. And please be member. I would request all the participants here. Join the APAS as a membership. Apply for it. We have got the website. So be member of that APAS group. Yeah. So
very good.
Thank you. Yeah. Dr. Fadullah Qasim. Yes. You are the main chap. He did a lot of job. For organizing this. He is my student. I told him you organize it and go on doing.
Yes, sir. Thank you, sir, for giving me the opportunity. And I am very much thankful to all, especially the Professor Rami Surial. It is you, sir, who given us time besides your very busy schedule, and the time zone is not suitable yet, then you manage it.
Yeah.
And Professor Nicholas and Shahid Noor is not here now, probably. We are also thankful to them. They given their wonderful time and knowledge to our beginner. And another panel of experts, of course, the pioneer of arthroplasty in Bangladesh, Professor Amjad Hussain. And he is also trying to organize it, not only personally he is doing, trying to organize it and the arthroplasty subspecialty in Bangladesh. We are trying to develop it with his help. I am thankful to Professor Hassan Masood, Dr. ATM Julfikur Rahman and Javed Jahangir to him for your brilliant presentation, and Dr. Shantanudhar Iman, your great moderation.
Yes, sir.
And thank you very much to all the participants. It is you who make this event successful, and we do hope you are benefited from our very learned and talented panel of experts today. And I want to announce now our next webinar will be on October 17. It is Saturday, as usual at 9 p.m. And we will go from the next 17, as usual, in every Saturday at 9 p.m. And here is, we are concluding our webinar on the total hip replacement. On the 17th October, we will start total knee replacement. And now, may I request Professor Amjad Hussain sir to conclude today's webinar. And if Professor Ram Surial, if you kindly give some concluding remark, please.
Yeah, that what I am thinking.
Yes.
Yeah, Rami, please. Boys are asking for your comment. Yeah.
Look, for inaugural webinar linked up with Dhaka and the rest of Bangladesh, I thought this was a very successful meeting. I thought the presentations were excellent, well put together, and you obviously have a reasonable amount of experience there just by the pathology you've just demonstrated. So look, we're more than happy to be part of the process in sharing information, knowledge with each other. We all learn at the end of the day by doing that. So thank you for inviting me. It was a pleasure to share this with you today.
Thank you, Rami. Good night to you and good afternoon to our people. Okay, thank you, Kashem, for your nice, organizing this thing. And our three presenters, really, they did a lot of hard work. What I should say, it is not easy to, to speak out with this August, faculties in front of them, particularly, but I'm so happy because they did a hard work for preparing this, their presentation. So thanks to everyone. And thanks to Shantanudhar, you nicely moderated and go on doing. Next time we'll be again inviting Rami and other people in our seminar, in our webinar, if visible. Yeah. Thank you everyone. Good night and good afternoon.
Good night.
Thank you.
Good evening.
Good night, Dr. Ravi.
Good night.
Thank you.
Thank you very much.